Okay, I'm a family physician. I'm in Welcome. I'm living there now 29 years. In the year 2006, I left the private sector, joined the public sector in the Department of Forensic Medicine. I'm still the clinical manager of forensic services in the Northern Free State to date. In the year 2009, I was diagnosed with Parkinson's disease, and it was discovered by my wife initially, who kept on complaining about me dragging my right leg.
I've noticed him walking out of the house, dragging his feet, and he just ignored me when I told him that, you're dragging your feet. And he said that he walks with his friends every day, and they haven't noticed anything.
I didn't believe her, didn't pay much attention to it. And being a doctor and walking around with doctor friends, nobody picked it up until we came to Durban. It was the Easter weekend in the year 2009. We brought all our staff for a treat to Durban, and it at the same time attended a family function. At the family function, those that they hadn't seen me for a long time began to ask questions about my leg, what happened to my leg. And I still didn't, I just put it over to maybe playing with the kids or playing soccer or something of that nature. But the last straw was when I went to Gateway that very night, and I saw a friend of mine from school who I hadn't seen for the past 20 years. And he began to question me that, did I have a stroke?
Yusuf and I are childhood friends. Yusuf relocated to Welcome, and I saw him I bumped into him at the Gateway Theatre of Shopping, and as he walked towards me, I saw him twitch and his hand go limp. So I said to him, "Hey, Doc, is there something wrong with you? Because you seem to have got a stroke." He said, "You know what, I'm a doctor. There's nothing wrong with me."
Too many people were saying too many things. And that very night, I came back home. I came to the flat. I was doing some assignment for the MBA that I was doing at that time, and got hold of Dr. Ridwan Katrada, who came over from the beach and diagnosed Parkinson's.
Dr. Vahed was having people asking him whether he's had a stroke. The symptoms that people were noticing was that he is tending to drag his right-hand side. There was an impairment in his gait. It looked like the right-hand side of his body wasn't moving as well. He was also experiencing some stiffness on the right-hand side, and he just felt a little more slow and lethargic as compared to his previous self. It's when I examined him, then I found some of the symptoms of Parkinson's disease itself. He had the most prominent symptom was stiffness on the right-hand side. That's one of the hallmarks of Parkinson's disease. The person becomes very stiff on one half of the body preferentially, and it can really look like a stroke, or they can feel like they're just not themselves, and they complain of poor energy levels and just feeling tired all the time. Notably for Dr. Vahed was that he didn't have much of a tremor, which is also a key feature of Parkinson's disease. Most people are familiar with the tremor where the patient sits and shakes, especially when they're sitting at rest. One would notice the hand shaking. So Dr. Vahed didn't have that. So yeah, it was the stiffness or the rigidity. Another symptom is called the akinesia or dyskinesia, which is difficulty with initiating movement especially. So when one tries to get up from a chair or get up from the bed, it's difficult, one is hesitant, there's difficulty standing and getting the right posture or balance. Once one stands for a little while, then the balance and the strength come back, and then you can start walking. Initially, the first few steps might also be a bit hesitant, shuffling, and you feel like you're going to fall. But once you start walking, then the rhythm and balance tend to settle in.
I was quite shocked and devastated, but knew that it was life and had to carry on. I managed to get over the bad thoughts of Parkinson's because I could see the end of the disease. And instead of worrying about the present, I was more worried about what was to come. And in that way, I was able to overcome the disease itself, or the bad thoughts of the disease, and reach where I am today. But Parkinson's disease is a neurodegenerative disease. By definition, it will get worse, and it must progress as time goes. How it progresses, how far it progresses, how severe it's going to be in an individual, nobody knows. And it's termed idiopathic Parkinson's disease. Idiopathic simply means we don't know. Doctors use the term idiopathic in issues of where they don't know what is the cause of the disease, and what is the outcome of the disease, or what's going to be the end result of the disease. So Parkinson's is regarded as an idiopathic disease in most instances. There are other types of Parkinson, secondary Parkinson, secondary to vascular trauma, like a stroke, or to trauma itself. And the bulk of the disease, or the majority of the disease, is idiopathic.
The treatment depends on the stage of the disease and the person's age. If there are other illnesses, one would generally tailor one's choice of treatment. Most commonly, one would start off with tablets, and there's a whole host of different tablets. The commonest, the idea is to replace the chemical dopamine. Dopamine is the chemical that is missing in Parkinson's disease, and this is normally made deep in the brain. The nerve cells that produce this dopamine are dying off for whatever reason. Most of the time, we don't find a reason for the dying off of the cells. One can think of Muhammad Ali, the boxer. He's got Parkinson's disease in response to all the years of boxing. So severe prolonged trauma can cause Parkinson's. But in the majority of cases, one doesn't find a cause. So it's the chemical dopamine that's missing, and there are various types of tablets that aim to replace that dopamine. Everybody's illness is different. So some people might be missing just a little bit of dopamine, others might be missing a lot. Some may be secreting no dopamine, others are secreting partial amounts, and there's a whole of a variety in between. So with assessment by a neurologist preferably, one can then assess what level the Parkinson's disease is, and then tailor medication appropriately. In the more severe cases, or where medication is not working so well, or there's side effects to medication, one then aims to use other treatments, and this is where the deep brain stimulation, a surgical therapy for Parkinson's, fits in. This is what Dr. Vahed had. It's a adjunct, and it's often used in conjunction with medication as well. Results from various tests have found that the combination of deep brain stimulation and medication often yields a much better result in the patient's quality of life, and that's what we're aiming for, a good quality of life. To get the procedure done, basically what is done is several number of fine micro wires are fed into a specific area of the brain, and this is quite deep. These are very thin micro wires, nanometers in length, so it's barely visible to the eye. Those fibers are then relayed back out of the head. The wires are passed under the skin, but outside of the skull, and fed to a small micro device like a pacemaker that sits on the chest wall. This then houses the batteries and feeds current through to those wires in the brain. What's some notables is that this is persistently on, and it can be programmed externally. So the neurologist would have a magnetic stimulator that he can change the stimulation rate on that the stimulator under the skin, and it's a matter of just holding the remote close to your skin, and he makes adjustments. The current is then adjusted for strength and rate, and is adjusted to the person's symptoms and side effects. And the combination of this with medication often, as I said, yields a much better quality of life and result for the patient. What the stimulator is doing is mimicking the dopamine that's not there. So in place of the dopamine coming through and stimulating that cell where the electrode is, the external current is now supplying that. So we're using an electrical stimulus in place of the body's missing chemical stimulus. Fortunately, the stimulator sits just under the skin on the chest wall. So the batteries that would eventually die off, but that's anywhere between 3 to 5 years. And so just a small incision just to replace the whole unit itself. That can be done very simply and easily. The actual wires themselves tend to stay in for much longer duration of time, so it isn't a matter of replacing all of these wires or going in periodically to change the cables or anything of that sort. It's generally the craniotomy, which is what the hole in the head is called, the operation to make the hole in the head. Generally that's a once-off episode with just the stimulator being changed at 3 to 5 year intervals. An important part to note is that the deep brain stimulation doesn't cure Parkinson's. It doesn't halt the disease. What it's doing is just supplying an incremental stimulus to the part of the brain that's deficient of the dopamine. So as the disease progresses, the body gets less and less of dopamine. What we can then do with the deep brain stimulator is increase the current by frequency and strength to replace that deficient dopamine. So it's not a cure. What it does do is improve quality of life. That's the main aim behind all of this. It's been found that the deep brain stimulation helps with 3 of the main symptoms of Parkinson's, namely the stiffness or rigidity. The second is the difficulty initiating movement. That's called akinesia. The deep brain stimulation eases that symptom as well. So while you might find it initially difficult to just get up off a chair like the ordinary person, with deep brain stimulation, that difficulty is lessened. The last symptom that it does help is the tremor. It does lessen tremor. It might not abolish it completely, but makes it much more bearable. Obviously, there's a variety and a range depending on the severity of the person's illness, but by and large, it would bring about a substantial decrease in the person's tremor. For Parkinson's, this is an increasing, an increasingly available modality of treatment. Most doctors and even neurologists are familiar with the medication. This is now proven to be a fairly safe, reliable, and efficient method for dealing with certain patients with Parkinson's. It's not all people or all Parkinson's patients that qualify for this, but the idea of this is that the doctor, either the GP or the neurologist, should keep this in mind as part of the armamentarium in treating Parkinson's patients. Thus far, the facilities for this operation are available, at least in Durban, Johannesburg and Cape Town. They may be available in Bloemfontein and Pretoria as well. So increasingly there is a presence where these facilities are available. Hopefully it will be available in most of the provinces, and is something that even if the patient doesn't qualify, at least should be offered the chance of screening for. I think that's the main aim in bringing about an awareness of deep brain stimulation. Besides Parkinson's, it's also used for other neurologic conditions where, namely tremor, what's called an essential tremor in patients who have just tremor but none of the other features of Parkinson's. That's another condition where it's used. And a third condition is what's called dystonia. These are involuntary writhing, twisting movements which some patients have. This has also been shown to help for dystonia patients as well. Features that would qualify a patient or would suggest that a patient evaluates deep brain stimulation seriously. One would look at a patient with more advanced, severe form of the disease. So if they're using medication very frequently, and there are the unfortunate patients who have to take tablets literally every hour to maintain their mobility and control their Parkinson's. So in a patient like that, where they need really large amounts of the dopamine replacement therapy. A second is where the medication is causing too much of side effects or is wearing off. So you take the dopamine replacement and it's not working as long as before. Previously it may have worked for 4 or 6 hours, a single dose. Now it's working for 1 or 2 hours and wearing off. As mentioned, also the dystonia. Some Parkinson's patients do develop dystonia, both as a complication of the disease as well as because of the treatment itself. Both can cause dystonia. So where this dystonia is now coming in, these patients are also better candidates for the deep brain stimulation. In a patient who has very mild Parkinson's disease, who's easily settled with just a once daily or twice daily tablets, I think those patients would be best served initially by just continuing with medical therapy.
Look, deep brain stimulation is definitely not a cure for Parkinson's disease. But what deep brain stimulation has done for me, it has given me a brand new lease in life. It has brought back my standard of living to the days of not having Parkinson, or to the days before being diagnosed with Parkinson's. What it has done, the most important, is that it has reduced the amount of medication that I take. From 7.5 tablets a day, I now take 1.5 to 2 tablets a day. Half a tablet every 4 hours. Sometimes just half a tablet in the morning and half a tablet at night. Since the body is depleted of dopamine, the body needs some dopamine to be replaced. But unfortunately, one of the main severe side effects of dopamine medication is dystonia. And dystonia, as was described earlier by Dr. Katrada, dystonia is quite severe involuntary muscular movements. I'm very, very fortunate. I don't have any more dystonias. I don't have the on and off periods where you feel that you don't have any medication in your system. And most importantly, I don't have the somnolence or the sleepiness, especially in the afternoons. Normally by 2 o'clock in the afternoon, if I haven't slept, I cannot work. I've got to go to sleep and take some medication. Now I have a full day of work. I can do jogging, running, and as I've said in the past, I've got a lot of unfinished business. I'd like to do some bungee jumping, some skydiving. I'd like to finish my private pilot's license and still fly the plane. Fortunately, I'm still driving around. I drive long distances in the Free State during my working hours. I come to Durban driving quite often, driving back to Valcom, and I'm leading a normal life. I would like to do some work, special work for Parkinson's Association of South Africa, and that is to try and raise funds. The Lotteries Board have withdrawn the subsidy to PASA, and I would like to climb Mount Kilimanjaro in aid of PASA, and I'd like to appeal or make this earnest appeal to all my friends and colleagues in the medical profession, my business associates, my family and friends, to please donate towards PASA. It's a wonderful organization that takes care of those who cannot afford. And I'd like to be a voice for the poor who cannot afford DBS. There are many, many people with Parkinson's disease who are not diagnosed properly, or should I say who are misdiagnosed, mismanaged, who deserve to have DBS much more than I, and who cannot afford it. And it's an appeal to the government to get involved as well, to make this DBS a life-changing operation, or should I say a life-changing procedure, available freely to the indigent of our country. And to all those who have Parkinson's, do not lose hope. I am a living example of what DBS or what DBS can do for you. A beautiful concept of DBS is the fact that it is reversible. In other words, if a cure for Parkinson comes up, the electrodes can be removed, the whole system can be removed. And what we would like to do is to demonstrate the effects of DBS. Dancing, you know. Come, no dance. Okay, let's do that. Can you see the difference? This is for rigidity. I don't have any tremors. Heel toe, but off stick. And to you all out there, my main message is live life to the fullest.